Well, thanks everyone who's jumping on. We will get started in about 2 minutes.
Yeah, I think it will be a great meeting.
Very timely.
Yeah.
You know, all the facilities are already asking about it. So yeah, definitely very timely.
Yeah, so true.
Yeah.
Yeah.
Are they asking more like yes or no? Should we get shots or not? Or like which ones should we get? Or timing or
Timing wise, and then I think most of the facilities know which one to give now. At least for the flu.
Nice. They have some more data out on, high dose flu vaccines and how helpful that they are.
Yeah.
Yeah, the data is really awesome. I wonder if Greg is on. Is this Greg for the iPhone?
Good question. I don't know.
I'm gonna go ahead and email Chad Fear. He's having trouble getting on. So let me email him and you guys could figure out.
Well, there's two coming through now. Joe Tansey, Pavitra Patel, and somebody whose name is not there. G. Baker, Liz here.
Nice.
Oh, here's Dr. Gahm.
Okay.
And Chris Horton.
Hey everyone, thanks for jumping on. We're gonna help our speakers get on too, and we'll get some very shortly here.
Looks like Chad's on now too.
Oh, good.
Yeah.
Perfect. Good to see everyone. It is 12 noon here in Colorado at least, and we welcome you to joining our October CMDA, new name PALTmed Colorado, monthly meeting. I'm Sing Pallet, the president of PALTmed Colorado, and today's meeting will be led by Dr. Vikas Reddy. So Dr. Reddy, why don't you go ahead?
Awesome. Yeah, no, thank you guys for joining. We got a few things on our agenda today. So we're going to start with Chad for any updates from CDPHE.
All right. Well, good afternoon. Yeah, so not a whole lot going on our end other than, managing and trying to figure our direction through the federal government shutdown. We did get some direction from CMS as far as the work that we can do, and I wanted to share that with everybody if you've not already been aware. In terms of survey, we will not be doing any recertification surveys, with the exception of the possibility of Medicaid only. Okay, we have 6 Medicaid-only facilities, and we may be able to do a recert there. But by and large, we will not be able to do recertification surveys. What we also will be able to do is IJ level and complaints with elements of harm in the allegation. So if that exists, we'll be doing a number of harm and IJ level complaints. For existing, for facilities where we have surveyed and we've exited, but you've not received the 2567, the deficiency list report, we will be holding those unless there was a citation of harm. as well as the survey activities that we're able to do. So if our findings include harm, we'll be able to process those. But if our findings do not include harm, we're going to have to put those in a parking lot until we get permission from CMS to proceed. So basically, once the shutdown is lifted, then we have 45 days to go back and complete the work that we're having to shelve. If you're aware, we've canceled IDR, and in terms of revisits, we're only able to complete revisits for those certified facilities. So, anything other than the Medicaid facilities, we can only do a revisit with CMS's permission, and only if the facility is within 45 days of termination. Now, I did with that want to say that the guidance that we've received also indicates that the daily CMPs for facilities will continue regardless of our ability to go out and complete the revisit. I think that's probably. There's a few other things, but I think it probably pertains to our surveyor activities more so. But I think that's probably a summary of where we are and what our engagement will look like with you and the community.
Thank you, Chad. Hopefully that all gets resolved pretty soon so everything can resume as soon as possible. But thank you for the update.
You bet.
Next, we'll have Jenny go to give us their update from CHCA.
Hi, everybody. I'm just going to dovetail into what Chad was talking about. There are some other agency updates in terms of besides CMS activities that are happening that affect our profession. So let me touch on a couple of things. First of all, I just want to put out a quick reminder, and I'll be going over this with our members this week, about COVID requirements, COVID vaccine requirements. A lot of folks have been asking, are we still required to track staff vaccination, for example? And the answer is yes, we are still supposed to track vaccination status. We can still get an F887 for COVID vaccine. We are required still to offer the vaccine and to educate staff and residents about it. So that has not changed. That remains within the CMS requirements. And then if you have any assisted living communities or continuum of care, they have a lesser requirement to have a plan implemented. Educating staff and residents is also required for them. And then an annual offering of vaccines more generally is required there. There is no tracking requirement for assisted livings. So I'll go over that with our members so they can be on the same page with you. A couple of other quick notes. The minimum staffing requirement that we had been anticipating from CMS has been dismissed completely. It is permanently eliminated. That does not mean that the implemented portions of that rule, the facility assessment, are going to be reversed. They will not be. So we are still required to track the acuity of our residents and gear our staffing and our structure of our organizations based upon the actual resident population that we have, which honestly, there was nothing different there. It's just that it is formalized in the format of a facility assessment. So surveyors can still ask to see it and tie tags to whether we have accurately adjusted our operation to match our population. So that maintains, but the minimum staffing requirement is not going to be implemented. CMS has released their priorities for fiscal year 2026. You can view that on their website. Not a lot of difference from what we've seen in the past, although I do want to note that they've changed some of the MDS requirements for how we assess our residents, particularly around effective discharge planning. You'll want to pay attention to this with your residents and their discharge planning. They removed a health-related social needs component from the MDS, but they are still strongly recommending that we ask questions pertaining to discharge. And of course, there's a lot of surveyor guidance around discharge planning, and we're seeing an increased number of citations around this issue. Your documentation as a provider as to what you believe the resident needs and should be provided with, where they are going, is essential to making sure we do not get deficiency citations in this area. So please collaborate with your teams on that. And then a last quick note here, OIG, the Office of Inspector General, has just released some new findings on nursing home fall reporting, and this connects to the MDS as well. It's all about falls with major injury. Some states do require, and I'm sure many of you have operated in other states, they do require a global fall reporting, kind of like our occurrence reporting. In Colorado, we do not do that. We report it through our MDS for the assessment component of it. Our reporting for falls is only in the event that it causes a spinal or a brain injury through the occurrence portal. We report that, but the OIG is hot to trot on this issue and is kind of reprimanding CMS for how well they've been able to capture that data on the MDS. They think that a lot of facilities are under-reporting falls with major injuries. So pay attention to that when it comes to IDT review in your QAPI meetings. It will probably need to come up as a review topic and something you can certainly encourage your other providers to look at with residents, particularly that are frequent fallers, to make sure they're capturing all that information and getting some good interventions in place. I think that's pretty much it for me today. Thank you.
Thank you. Does anybody have any questions for Jenny? Okay. All right. We're also at the time where we're going to be doing re-elections for the board at large members. So we wanted to give an opportunity for a few of our candidates, returning candidates, to talk about their experience and why they want to continue on with the board. In the next couple of weeks, everybody that's part of CMDA will get a voting ballot. Correct me if I'm wrong, Singh.
Yes, the people who are paid members of PALTmed Colorado or CMDA will get a chance to vote. So actually, this is a great time to renew your membership online. Go to cmda.us and go to the membership part and renew it. Or if you've never been a member, now would be a great time to become a member, and then you'll be allowed to vote in the elections. We'll have them online from October 10th to 17th, and just the people who are current members will get a ballot.
And if anyone else is interested, also let us know if you want to be interested at the board at large as well. So I think Leah's here. Leah, if you want to take a minute to discuss your reelection.
Sorry about that. Took me a minute to unmute myself. Yeah, so no, I've really enjoyed being part of this organization and helping with keeping everybody up to date with the most up-to-date evidence that we have. And so yeah, I would love to continue to participate and help disseminate this information that I think is so vital.
Awesome. And she was a very active, member at the board over this last year, and took a huge challenge of getting cupcakes, ready for us for the annual conference. So that was a big undertaking as well, and providing education, throughout the state. So thank you, Leah, and for the time.
My pleasure.
Is Valerie on?
I don't see her on here. And I don't see Rajrai on here either.
Gotcha. Okay. Yeah, so the other two members is Dr. Raj Rai, and Valerie Slade. So you'll get their names on the ballot as well. They were both, part of the board at large for previous years, so they're running for re-election. Okay, then we can move on. So Dr. Eber will do the next presentation on vaccines.
Thank you so much. Welcome to everybody to the CMDA monthly meeting. So I've got two parts to my presentation. In the first part, you just get to look at each other and listen because it's pre-publication information. So I wanted to update you on what PALTmed's going to recommend for vaccines for our space, for post-acute and long-term care. It includes nursing homes and assisted living and that whole spectrum. And so PALTmed recommendations for vaccines for 2025, 2026 are written, but they're being codified. Two more groups to make sure that everything is perfect. They were written by two infectious disease doctors and our entire PALTmed infectious disease committee. So I want to thank them. And we'll include all the references that you need. And so hopefully, we feel strongly that this will be the standard of care for vaccination in post-acute and long-term care medicine for 2025, 2026. And they've made 4 recommendations. I can't show it to you in print, but you are welcome to write them down. So PALTmed recommends routine vaccination for residents and staff who do not have contraindications as described below. Number 1. All residents over 18 years old should receive 1 dose of the 2025-2026 COVID-19 vaccine, given at least 2 months after any previous COVID-19 vaccine doses. And this is, there are recommendations for COVID-19 vaccination. And we will also have a cheat sheet for the other vaccinations, but these 4 recommendations only apply to COVID-19 for right now. Number 2, residents with moderate to severe immunocompromised status should receive at least 2 doses of the 2025-2026 COVID-19 vaccine, and preferably they should be dosed 6 months apart, but you can give as soon as 2 months after your original COVID-19 vaccination, especially during an outbreak that may be needed. Additional doses may be given after 2 months for these patients based on shared clinical decision-making. Number 3, for the staff. All clinical, non-clinical staff, vendors, contractors, trainees in post-acute and long-term care facilities should receive at least 1 dose of the 2025-2026 COVID-19 vaccine. And this is a strong recommendation. Some staff may need additional doses for those who have moderate to severe immunocompromised status. And number 4, vaccine selection. Really, any COVID-19 vaccine licensed by the FDA is fine. That includes Pfizer, Moderna, Novavax, as long as it's good for the appropriate age group that you are a part of. I wanted to give you 2 side notes for these recommendations. Staff vaccination is really couched in resident safety. We want the staff to be vaccinated because it does add a layer of safety for our residents. The data on prevention of transmission from a COVID-19 vaccine is really limited, but vaccination may support some decreased transmission between staff and residents, also between staff and their household contacts. Vaccination supports adequate staffing levels within our facilities. And so that's an added benefit, of course, less sick days. If you do not want to be out for 7 to 10 days as a staff member, then getting the COVID-19 vaccine is a really good choice. Additionally, staff and resident vaccination can decrease the risk of facility COVID-19 outbreaks, which increases medical risk for both staff and residents, is really costly, and as we all know, is a huge lift for our facilities. Being in an outbreak is no fun. If you'd like to decrease your risk of having a COVID-19 outbreak, the more staff and residents that are vaccinated, of course, that's going to help you out. So those are the recommendations from PALTmed. They should be published, we're hoping, early next week, and you'll see that come in your email if you are a member of PALTmed, which I hope you guys are. This is a useful thing. There'll also be kind of a chart that will be helpful that you can share with your facilities. Does anybody have any question about the recommendations from PALTmed that are pending in just hopefully 6 days? It's very quiet today. Okay. Well, if you have any questions, please feel free to put it in the chat or unmute. Would love to hear your perspectives or any concerns or questions. The second part of my presentation is with some visuals. Hold on. Okay. Okay, hold on. We're not going to start there. Can you guys see my presentation slides?
Yep.
Is it okay?
Yes.
Okay. All right. Well, let's give it a go. Okay. So an update on Colorado specifics for COVID-19 vaccination 2025-2026. Governor Polis and the Colorado Department of Public Health and Environment issued a public health order September 3rd, 2025, to allow pharmacists to provide COVID-19 vaccines without individual prescriptions. You shouldn't need a prescription anywhere you go to get a COVID-19 vaccine. Standing order took effect on Friday, September 5th. And so that should ease access for our staff members if they don't choose to get vaccinated in your facility. If you have a vaccine clinic, they should be able to go elsewhere and have no issues getting a vaccine. And so then I thought we'd talk a little bit about how to talk about vaccinations, because it's a challenge. We really do know that. It's a hard time to talk about vaccines. People are tired about the vaccine discussion and education. They're burnt out on respiratory infection conversations. And most of us are just asking, are we done yet? Are we there yet? Is it over? So some solutions that you could use in your everyday practices is if you're talking about vaccination or any kind of education, start with things that are interesting to your audience. Know your audience and see what questions that they have. Are they wondering about what the latest variant is? Are they wondering if COVID-19 is in, your local area? Is it a thing? What do we expect for this year? And so find out what interests people and assume the answer is yes. Make it a usual standard of care for both residents and staff to get vaccinated. We get a flu shot, we get a COVID-19 vaccine. It's great if it can be the standard of care. If you have fall and spring vaccine clinics, make it fun, make it rewarding, and make it so that they see all of you getting your vaccines. And if you have thought leaders and influencers in your communities, ask them to partner with them so that everyone can see that they're getting vaccinated. One of the things we can do to make it easier for ourselves, I'm going to talk about this a little bit more, is using a multi-use consent form upon admission. This can make it easier who wants to get a separate consent for every single vaccine, even though you don't need a consent for these vaccines, especially with the new ACIP recommendation for shared decision making. And a lot of chains really want these consent forms. So even though they're not mandated legally, many people are using them. It's great if you can just use one. Talk about the benefits today. I often say that it's one shot on one day and you save yourself often 7 to 10 days at home being sick and getting others sick. And again, make it as easy as possible. Some facilities I know will give you an hour of PTO to go get your vaccination. Okay. Oh, goodness. All right. So it's not only what you say, of course, but how you say it. And here are some pearls for when you're talking about vaccines. Be authentic, be relatable. Don't use a script. Meet people where they are, find common ground. Some of the wording that I like to say if I'm talking to a family is, we both want your mom to do well. We want her to have as high a quality of life, and we don't want her to spend, any time at all, if possible, in the hospital. I really am an admirer of Dr. Kimberly Manning from Emory. She's fantastic, and she would always say, don't just wag your finger and tell me what to do. That doesn't usually work. You don't have to seal the deal during this one conversation. You can simply open up the door, and that often can lead to some consideration about vaccination in people who are wondering, they're hesitant, but they don't want to feel pressured or marginalized. Take your time and show that you care. People respond to what they feel. They can tell if you're just kind of going through the motions or if you have some skin in the game. they really want to understand that you care about them as people, anybody you're talking to, and that you are ready to listen to their concerns, ask questions, always show respect. Everybody wants to feel valued, and nobody wants to be marginalized or feel that they are not intelligent or they're asking a dumb question. Nobody wants to feel that way, and that often shuts the door. And what I find to be really useful is doing a combination of telling people about some data and the statistics. How is the flu vaccine working for 2025, 2026? What about the COVID-19 vaccine? But then share your personal story. I often talk about, why my kids, they're 24 and 27, and why it's important to me that they get their COVID-19 vaccine. Last year, we all, were vaccinated. My mom was struggling with cancer, and it was really important that everybody got vaccinated. Making it a human conversation is really important, and it often resonates. Okay. Let's see here. Oh, sorry. Okay. I wanted just to let you know this is free, available to everybody. It's a guide to supporting effective immunization practices in post-acute and long-term care. It has so many usable parts. It's kind of a big document. I gave you the website right here, Moving Needles Guide, and I'll show you with my pointer. This is the website that you can go to. You'll get these slides. And they're trying to make it much easier to make immunization a standard of care in post-acute and long-term care for residents, and an expectation for staff as well. And they give you all sorts of things to use. I'm just going to show you 2 or 3 slides that really resonated with me. I love the Swiss cheese model. It's like my favorite thing. It shows you that the layers of defense really can help your facility stay out of that outbreak situation. If you vaccinate staff, if you have residents that are vaccinated, if you do good hand washing, all of these Swiss cheese pieces work together and help you so that you can have a healthier staff, a healthier resident population, and not deal with an outbreak. Okay. And I really love this one from the CDC. It's called the SHARE model for, I'm going to go back. Sorry, hang in here with me. For vaccine recommendations. Share the reasons why immunizations are important. What are the benefits? Highlight positive experiences. Address people's questions and be open to them. What they did find through the research on staff in post-acute and long-term care, I was part of these surveys, so I gathered some of this data. Staff really want a balanced view of vaccination. They don't want a sales pitch. They want to know the pluses, and they want to know some of the risks. And so we have to be really intentional and honest when we have these conversations and not be one-sided. Remind people that immunization not only protects them, but provides a layer of protection for the people that they love and care for. And explain the possible negative impacts of getting a vaccine so that we're honest and truthful. And that shows not only our integrity, but our authenticity. This is the other one I really like. Who would not want 7 tips for a successful immunization clinic in our facility? Something you can use at QAPI, and I found really useful. And this is the multiple vaccine consent form. If you don't have one through your facility, this one has been endorsed by the National Community Pharmacists Association. Sorry about that. And that is it. So that is what I wanted to share with everybody today. I hope it was useful, and I didn't know if anybody had any questions.
And there's one question in the chat box from Singh. Do you know if other medical organizations will be recommending COVID vaccines for healthcare staff? I'm pleased that PALTmed is recommending it. Thank you, Dr. Eber.
Well, thanks, Singh. I don't know for sure. I think that PALTmed is going to be one of the first. Most medical associations have a process by which they develop vaccine recommendations. I know the ACP and the AMA are in the middle of that process as well as the IDSA, Infectious Disease Society of America. We've really worked hard at PALTmed to move that process along quickly, maintaining the integrity of the recommendations. I don't know if the American College of Physicians are going to recommend for healthcare staff vaccination, but we have a communication line with them, And so I think that they're still working on it. I don't know. I know that AGS is also thinking about what their vaccine recommendations are going to be, the American Geriatric Society. So I think that these are unknowns. As soon as we find out, and as soon as the ACP recommendations come out as well, we'll make sure to share those with you, and I'm hopeful that they'll be aligned with the PALTmed recommendations. But I think PALTmed may be the first one to publish their recommendations. And so hopefully that will be useful to all of you in your facilities. I hope that answers the question.
Awesome. Thank you, Dr. Eber. And yeah, those tips are definitely useful as everyone is witnessing the vaccine fatigue, and try to be genuine and meet people kind of where they're at. So it's definitely good tips. So thank you very much.
Thank you.
All right. And then next we'll have Dr. Gahm, continued discussion on vaccines.
Yeah, great. I'm going to try to share this, see if that works. Share. Did that come through?
Yep.
Oh, good. All right. Okay, so this is really a follow-up to what Leslie already did that was wonderful, and we'll just add some more pieces to it. So I'm going to start with one other group that's all for vaccines. So let's see, I have to move this out of the way, I think. There we go. The AHIP, American Health Insurance Plans. We, of course, want to know what the insurance companies are doing. I love this because they're committed to continuing to vaccinate. But I love that they also came up with this, that they're going to do the ACIP recommended immunizations that were recommended by September 1st, which is, of course, when the new ACIP panel that is, let's say, less capable was appointed. So these are based on the opinions of the more capable ACIP that was dismissed. This is sort of their disclaimer. While health plans operate in an environment shaped by federal and state laws and so forth, they're going to continue to use an evidence-based approach to coverage of immunizations. And again, do they impact what United or Cigna or Kaiser or anybody else does? Probably not by themselves, but as a group, they all do the same thing. They have, I think, some authority. I don't know. It's a brave new world. So vaccine coverage, Part B covers influenza, pneumonia, COVID. Under Part D plans, RSV and shingles. So I'm just going to touch briefly, not as much on COVID, because Leslie did such a nice job, but briefly touch on the others. Influenza vaccine is available for distribution now. I don't know how many facilities have already received it. I know as I check, quite a few have, but there are still a number that have not. This year's vaccine is trivalent. 2 years ago was the last year, at least for the near future here, for the quadrivalent vaccine because it had two B vaccines, and one of those Bs really has disappeared in the world. The influenza B takes about every 10 years before it changes, and the other B that was there is gone. The A strains, H1N1 and H3N2, really change about every 2 years, sometimes every 3 years. And of all of these, it's the H3N2 is the one that's most significant for our patients in nursing homes. This is the one that makes them sick and puts them in the hospital. H1N1 is primarily kids and adolescents. And B, because it lasts so long, most of our patients have already got lifetime immunity, a whole bunch of strains of B, so it is seldom terribly symptomatic. When to vaccinate? So if you have staff and whatever healthy means, but healthy persons under age 65, anytime you get the vaccine is a fine time to give it. In a typical adult, the immunity is going to last for about a year. In a healthy adolescent, about a year and a half. So it lasts the whole season, not a problem. Sicker persons, so under 65, but you've got COPD or cancer, immunosuppressive states, heart disease, treat those folks as if they were over 65. So anybody over 65 or sicker, my recommendation, the party line out there in the community is vaccinate as soon as you get them. And it's really based on a community model where you may, in your clinic, only see these patients once in October, November, December, may not see them again. So get them while you got them. And that makes sense. Our population, other than rehab patients, where you should take that approach and, either educate or vaccinate while you have them. The rest of our folks are really a captive audience. And I recommend that you vaccinate closer to Thanksgiving or even after, anytime in December. And the reason for that is in seniors, immunity begins to wane after 90 days. By 90 days, about a quarter, about 25% of folks that were vaccinated, that their immunity is really just gone. And by 120 days, it's significantly higher than that. So if we give the vaccination now, say October 1st, November, December, by January 1st, a quarter of our folks aren't immune anymore. So I just say, hold off. We typically will see our peak in Colorado for influenza. Mid-January to mid-February would be the worst historically. We have had some early seasons, especially with COVID. We've had a couple that have been particularly early. And if that happens, you just give it to them. We see it coming. Luckily, all the influenza attacks the coasts, Texas, Florida, Alaska, Hawaii, New York, they all get hit first. So we usually get warning when it's coming. Which vaccine? Anybody over 65 or those folks we talked about a minute ago who are sick, especially if they have diseases compromising your immune system, should get either the high dose or the adjuvant vaccine. Everybody else, the standard trivalent vaccine is just fine. And we're going to look a little bit at this. There's just data from last week about the cardiovascular disease. I'll touch on that again in a minute. So MMWR, just a little more than a week ago, pediatric influenza cases and hospitalizations have to be reported, so they do a much better job of tracking, but they're also reflective of the general population. They just 10 days ago reported the summary of what happened last flu season. We had a record number of pediatric influenza deaths in the US. And then this is the part that should really be scaring us. There were 109 cases of influenza-associated encephalopathy, acute necrotizing encephalopathy last flu season. Half of those 109 people were completely healthy prior to getting influenza. 21 of those 109 died. And then comes the scary part. Of the other 88, half of them never recovered neurologically and won't. So these are kids that got, oh, and by the way, just to point out, only 16% of the 109 were vaccinated. 84%, 5 out of 6, were not vaccinated. And these are really bad things. You get these things. This is welcome to your new home. You live in a ward with feeding tubes, and you can't talk, you can't walk, you can't do anything. It's reminiscent of the 1940s in the sort of wards full of people like this that we had. This is just really scary to me. All right, enough about that. We are lucky in the Northern Hemisphere because the Southern Hemisphere gets flu an entire season before we do. So we get all of their experience. We almost always use the same vaccines, but we get to see how well they're going to work. Vaccination in the Southern Hemisphere this year worked really well. Reduced hospitalizations by 50% if you were vaccinated. And again, it's the same sort of numbers here. Of the people in the Southern Hemisphere who had flu, and were sick enough to be hospitalized, only 1 in 6, 15%, were vaccinated. So it really does work. All right. More, this is from August in JAMA Cardiology, a randomized controlled trial from a Danish study that looked at the nationwide health registries from over a 3-year period of influenza, looking only at adults over age 64. And what they were looking at is severe cardiovascular outcomes that happened 14 days or more after vaccination and through May 31st. Again, 332,000 participants were randomized to either standard or high dose vaccine. 91,000, just under a third of those folks had a history of cardiovascular disease. In their study, the high dose vaccine did not significantly reduce hospitalizations for influenza or pneumonia. But the incidence of hospitalization for cardiovascular disease was significantly lower in the high dose group versus standard by 7.5%, and in particular, heart failure. I don't know. The theory behind this is you get influenza, you get pulmonary compromise, you get a little hypoxic, it adds to cardiac strain, which increases your risk for angina, heart attacks, heart failure. So anyway, get the vaccine, 7.5% decreased risk of cardiovascular disease there. Okay. Flu vaccine, enough. Pneumococcal vaccine, strep pneumoniae, still common. Bacterial-caused pneumonia in adults, causing a lot of deaths, just about 100 subtypes. And this is a plea to quit doing what I see happening still, giving Prevnar 20. So Prevnar 20 is a really fine vaccine. And when it came out 6 years ago, it was top notch. It was the best there was. In 2025, it hits 52% of the pneumococcal subtypes that are actually circulating. Prevnar 21, also called Capvaxive, is 84 to 88% effective against the subtypes that are circulating. So if you just look at those two numbers, you can figure out which one you should use if your goal really is to protect patients. If they're going to go ahead and get the vaccine and you're going to give it to them and you have to have the talk and get them there, at least give them the best one. And again, this is covered. I talked to you about how it's Part D or Part B, but it is covered. Give them the right vaccine. Quit ordering Prevnar 20. And again, it used to be best. And in 5 years, Prevnar 21 won't be the best vaccine because it's effective enough that it will move to different subtypes. COVID, this is just a reminder. There were 1.226 million Americans that died from COVID. There were no medications that reduced deaths. Some, like ivermectin, led to increased side effects and increased deaths. But if you look at the graphs of when people died, when vaccines started, the mortality went down once the mRNA and the other vaccines were widely used. And it is important to continue to get, for all of us, to stay caught up, because even if you don't care about yourself, care that you might get long COVID if you get it, but care that you don't spread it to somebody else. And Leslie talked about this. We'll skip that. Jump to RSV. RSV, viral lung disease, usually mild cold-like symptoms. It's the leading cause of infant hospitalizations in the US. It's a more prevalent cause of illness and death in seniors. Really, in the last 10 years, we've seen this going up. And just to give you an idea how much, in last year, 100 to 150,000 RSV-associated hospitalizations in adults over age 60. So it's not non-existent, it's out there. Vaccines really are effective. If you look at all the vaccines out there, Shingrix, MMR, RSV, far and away the three most effective vaccines. Influenza, less efficacious but important, like we just saw, and then the others are somewhere in between. This is a really nice study. 7,000 participants taken from CDC data. RSV vaccines were 58% effective at preventing RSV hospitalizations. Again, this is in older adults across 2 seasons, but it decreased all-cause cardiorespiratory hospitalizations by about 10%. And there were lower rates of stroke, heart attack, hospitalization, all 3. And again, this, like flu vaccine, shows that it has downstream cardioprotective effects. There was another Danish RSV trial, again, huge number of patients. And it's because the Scandinavian countries all have these wonderful databases, socialized medicine, they track everything. So they can do all kinds of studies. We can't. Vaccine recipients in this study, again, parallels with the CDC saw, 10% less likely to have all-cause cardiorespiratory hospitalizations. Okay, let's move to shingles. This is the wrong audience. I mean, this slide is really made for the general public. You guys know what shingles look like and what patients go through. You don't want to go through it. Get the vaccine. It's a wonderful vaccine. Of all the vaccines, it is the one, it's 2 shots, 6 months apart, and it is the one, when you get that second shot, you're going to be down for the count for about 24 to 36 hours. A lot of fatigue, soreness, but that's better than getting shingles and spending weeks, months, or years with excruciating pain and problems. Anybody over age 50, you should consider getting this. A few other things about just vaccines in general. There really is no more effective, safer means to be protected from respiratory viruses. Stay up to date with vaccines. This is important, and it gets overlooked because life is busy. When your facilities receive their vaccine, now they're going to come in a styrofoam box, and they're going to have dry ice, and they're going to be cold, and the whole thing. But somebody may open that, just leave it sitting out for somebody else to put away. Don't let it happen. Get them to your vaccine refrigerator. Keep them in there. It only takes about 4 to 5 minutes at room temperature, and most vaccines become inert, just saline. When you give the vaccines, this is important. You don't want to take them where you kept checking twice daily, check vaccine temperature log to make sure that they stayed at the right 36 to 46 degrees. And then you take them out of there, you put them on the cart with all your supplies for giving shots, and you roll down the hallway over the next hour and give shots. And by the time you get to the 3rd room, you're no longer given vaccine. You're just given saline shots. So keep in mind, you got to keep them refrigerated really until that last 2 or 3 minutes. Couple quick comments. MMR. This is, I don't know if you don't need to know a whole lot about this. This is MMR, measles cases, mumps, measles, mumps, rubella, vaccination rates, and you can see vaccination rates dropping off. 2019 was a peak year for measles, clear up until, oh yeah, this year. Look where we are this year, and this was only 5 months, well, 4.5 months of data. In 4.5 months in 2025, we've seen the second highest number of measles cases in the US that we've seen going back for 15 years. And this is only halfway through the year. And again, it correlates really well with the drop-off in vaccination. Yeah, from yesterday, Reuters published this. The Americas region, so that's North, South America, Caribbean, or is it Canada, Mexico, and the US are at risk of losing their measles-free status? It's like, so what? But it is an important thing because characterizes a whole bunch of things. It's sort of like going to a TB endemic zone. We're soon going to be a measles endemic zone for travelers, and this will cut into folks coming here to travel. To be considered measles free, if you have an outbreak of measles, you have to get back to 0 cases within 12 months. That ends the end of this Canada. And we have until January, Mexico until February. The way things are going, we're not going to get there. The group that presented this was at a conference in London, got published yesterday. They didn't criticize any specific country, but did emphasize the importance of accurate public information to ensure vaccination rates don't fall. As a follow-up to that, according to WHO, 95% of your population needs to be vaccinated to prevent spread of measles. In Canada, according to their data, only 92% got the first dose and only 79% the second dose, so they're not going to be fully protected. This year has seen more than 5,000 cases in Canada with 2 deaths, and most recently a newborn in Alberta died. Stop sharing. That's it for vaccines. Any questions or comments?
We have Dr. Pallet raised her hand.
Want to go? Yeah, thank you, Greg. That was really great, and appreciate the thorough review of the different vaccines. Just 2 ideas I thought to add. When you recommend the PCV21 vaccination, I agree it has broader coverage of the various serotypes, but it's not an exact overlap with the PCV20. And I just wanted to, one thing I had read was that the PCV20 is considered potentially preferred for some populations, including some people in Colorado, people in the Navajo Nation, and in people who are younger than 65 who have chronic lung disease as well as other comorbidities. That there might be still a role for PCV20 that I'm going to keep in mind in case we have patients in that category. And the other,
there are some micro populations where it would be preferred, but you don't want to be so focused on that you lose the sight of the fact that 98% of the people don't fall in those micro populations.
yeah. And in similar measles, I know you said maybe we don't need to know a lot about measles, but I kind of think we do. Our staff members who are coming in and out of the buildings, who are traveling, who have children, who are coming in contact with people who are not in the nursing homes, I'm thinking that they're going to be the conduits for bringing measles into facilities if that's going to happen. And so I've been trying to tell the staff that I work with, the employees that I work with, more about measles so that we can be more aware and be prepared.
Agreed. My father-in-law was on the ACIP vaccine recommendation committee for about 10 years. And I see him 5 or 6 times a week. And we've had a lot of these conversations. And we talked about the influenza-associated encephalopathy. But he talks a lot, too, about just the measles encephalitis and all the kids. I mean, he's in his mid-90s now, so he was around in the 40s and 50s when all these kids that got measles encephalitis, and as a permanent thing, were just housed in these warehouses full of kids they didn't have a lot of tube feeding, but they were trying to feed them and keep them alive because we're not ready to let them die, but they just get disowned and left. And we're headed that direction again. And he said it was just awful. In fact, he told me last week, he's glad he's 95 and he's going to die soon because he spent his life, dealing with issues like this, and he doesn't want to be around to see it come back, that we didn't learn the lesson from history.
Anybody else have any questions, comments?
Just one more thing about measles. I think it's such a great point and a great conversation. Thank you so much, Greg and Singh. PALTmed has some information that you can share with staff about the measles. What would we expect for symptoms? What's the incubation period? And I've got like 3 slides if you want. We can share them so that you know, some easy information that you can share with staff so that you can recognize measles and know what you're looking for, along with some recommendations for vaccinations. So that maybe that will be useful as well, because I think it's been a long time since probably any of us have seen measles. I think it would be sometimes hard to surmise that that's what we're seeing. And of course, the rash comes a little bit later, and so other symptoms, upper respiratory symptoms can be first. And the incubation period, I want to make sure I say this right. Let's take a look. Make sure. Hold on. Oh, I just had it because I was just looking at it. Incubation period. Oh, to the fever, 7 to 10 days. Incubation period to the rash, 10 to 14 days after you have symptoms.
Yeah, I'll bet that there are, as I'm looking at this participant list, there are 2 or 3 of us on here that had measles. I would just bet. I'm one of them.
Oh gosh, wow. I did not have measles. No. I'm okay with it.
We had, when I was growing up, and I'm curious from Roger or anybody else, but when I was growing, oh, and Dave too. When I was growing, we had neighborhood measles parties, so that if somebody in your neighborhood got measles, all the kids went to their house and you all got it together.
Hmm.
I'm curious if anybody's recommending mass measles titers for our population. It would mean a lot of lab draws for very little benefit.
Yeah, I think, if you got the vaccine anytime after 1967, vaccine became available in 1957. But the one from 57 to 67 was significantly less effective than the updated vaccine in 67. If you've been vaccinated since 1967, you don't need to check titers. But if you weren't vaccinated, but you were born before 1957, you don't need to check titers. It's that 57 to 67 age group that you'd have to think about.
Thank you.
And if the person doesn't know if they were vaccinated or not, maybe they were just unaware, but vaccine titers are so expensive, and I wouldn't recommend that facilities kind of go on a mission to do all these vaccine titers. I think that would be very costly and not very effective. So just like Greg was saying, certainly if you're born before 1957, there's no need to do a titer if you know that you were vaccinated. And so I think titers have a very small space in our post-acute long-term care for usefulness.
Agreed.
I think some of the titers can also have a negative result, even if someone is truly immune due to a different part of the immune system. And another way to prove that you might be immune to measles is if you have a documented history of a measles infection. So maybe there are other ways of doing it besides a titer.
Agreed. I think the most important thing is to understand what it might look like with symptoms and incubation so that, I hope it doesn't happen in any of our nursing homes, but it's always nice to have that information.
Hi, this is Dave Shepard. Can you guys hear me okay?
Yeah.
So a few months ago, I actually kind of went over the symptoms and stuff with most of my facilities just so they'd know if they ever saw it. I don't think we can require people to collect the information from staff about MMR vaccination, but they could volunteer it. And if we ever did have an outbreak, it'd be nice to know who should or should not be working. And I also shared with them the R0 value, the infectivity rate of measles.
Yeah.
Early COVID was like 2, 3, 4. I think the Omicron variant was like 10 to 12 for the R0 value, and measles is, I think it's even higher. It's like 12 or something like that. So, if you're in a room with 100 people, most of those people are walking out with exposure.
Yeah, that's one of the conversations I was doing a nursing and CNA educational update, and we talked about measles. And I'm like, if one of us had measles, how many of us, if we were all not vaccinated, would get measles? And I think that they were surprised at, the number was so high because the R0 is so high. It's so contagious. But the vaccine is unbelievably effective.
Hey, this is John Hall. Hope you guys can hear me. I just had a question, something if you guys could talk a little bit about, particularly in our facilities, if we do have a positive COVID or a positive flu or, God forbid, positive measles, with regards to isolation and patient rights. I know I've got a facility where someone tested positive for COVID and they refused to stay in the room. They refused to wear a mask. They refused all the isolation barriers. They continued to drive their wheelchair all around the unit and cough everywhere. And it was quite unsettling. So I'm just wondering if you guys could talk a little bit about that, what we could do as providers to try to educate those patients and, offer what best support we can do for them.
I hate always picking on Joe and Chad, but I'd like to pick on Joe and Chad.
I know that Joe is here.
Oh, yeah. I think Chad signed up, but Joe is still here.
Yeah, I am here. I was looking to see if he was here to see if he would answer, but I don't see him. So, we would certainly expect you to do your best to isolate them and recognizing resident rights, but you also have to recognize resident rights of the other folks not to be exposed and possibly get measles or whatever. So I probably don't have a really good answer right off the top of my head right now, but I think we obviously should all talk about this and see what we could do, because you're right. They have residents have the right to go out, but they don't have the right to endanger other residents as well. So I know some communities came up with some fairly creative ways to isolate people during COVID. So we may need to rethink about all of those again. It's like, man, I just don't want to think about this stuff anymore. But so I think we need to bring out some of those things that we did and talk about those and share those and remember the kinds of things that we did for that. I know that's a non-answer, but I'm glad you brought it up though, so we can start thinking about it. And
Yeah, I just wanted to put it
be
on
better
people's radar.
prepared than we were. Yeah.
Yeah, because I feel like it can be an issue. And
Yes.
yes, patients have the right to do what they want, but when they're endangering other people, where do we draw the line? Mhm.
Yeah. So, okay, I think we should not stop with the conversation here, but we need to continue that conversation for sure.
Yeah,
And I will talk with Chad and at least have some ideas about maybe we can help present for consideration as well. So
Perfect. Thank you.
thank you for bringing that up.
Yeah, no, thank you guys. We're a little past 1, so thank you everybody for your time, and definitely a vital part of the year regarding vaccines and ensuring that all our residents are at least getting asked and getting as high of acceptance percentage as possible over this next couple of months. So yeah, but if nobody has anything else, then we will convene again next month in November.
Thank you.
Thank you guys.
Thanks, everyone.
Thanks.
And, Dr. Birmingham had a question in the chat box.
Oh,
Maybe we can just get back
yeah,
to him.
I just now read it. If you wait 5 or 6 years, yeah, I would. So for me, I would revaccinate. The subtypes evolve, they change. So if it's been more than 5 to 7 years, I would get the updated vaccine. I'll get in touch with Roger, let him know.
And also, the CDC has like a little cheat sheet of if it's been more than 3 to 5 years, your options, and I always found that really helpful as well.
Yep.
Oh yeah.
Thanks.
Yeah. Thanks.
And thanks, everyone.
Thanks, Sing. Bye, everybody.
Is everyone up? Are we still recording?